Learn the 2 red flags and the safest next step for resistant hypertension in pregnancy. EndlessMedical.Academy Educational Case. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine, Board-Certified Nephrologist, Certified Hypertension Specialist, Internal Medicine Specialist. See video description for disclosures. A 32-year-old gravida 2-para-1 woman at 24 weeks gestation is referred for evaluation of persistent hypertension despite pregnancy-compatible triple therapy. Hypertension was first noted 3 years ago and has worsened during this pregnancy. Current medications include nifedipine extended-release 60 mg daily and labetalol 600 mg twice daily, selected as first-line agents for hypertension in pregnancy per obstetric guidelines, hydroxychloroquine 200 mg twice daily, continued for rheumatoid arthritis and considered safe in pregnancy, low-dose aspirin 81 mg daily for preeclampsia prophylaxis in this high-risk pregnancy, and an antiretroviral regimen of tenofovir alafenamide emtricitabine plus dolutegravir per current U.S. perinatal human immunodeficiency virus guidelines, most recent viral load, undetectable, cluster of differentiation 4 count 620 per microliter. Methyldopa was tried earlier in gestation but stopped because of severe fatigue. Home and office blood pressures average 150 to 160 over 90 to 100 millimeters of mercury. At today's visit, vital signs are temperature 36.7 degrees Celsius, pulse 96 per minute, respiration 16 per minute, and blood pressure 148 over 96 millimeters of mercury, confirmed on 2 additional seated readings. She reports intermittent occipital headaches and has had 2 emergency department visits for sudden onset dyspnea that were managed as flash pulmonary edema. She denies visual changes, seizures, and chest pain. Physical examination reveals a gravid uterus appropriate for dates, clear lung fields, a hyperdynamic precordium without murmurs, and a high-pitched continuous bruit in the right periumbilical region radiating to the flank. No peripheral edema is present. Selected fasting laboratory results seated: sodium 140 millimoles per liter, potassium 3.1 millimoles per liter, chloride 104 millimoles per liter, bicarbonate 24 millimoles per liter, creatinine 0.7 milligrams per deciliter, estimated glomerular filtration rate greater than 90 milliliters per minute per 1.73 square meters, 24-hour urine protein 180 milligrams, plasma aldosterone concentration 38 nanograms per deciliter, pregnancy reference less than or equal to 40 nanograms per deciliter, plasma active renin concentration 8.5 nanograms per milliliter per hour, pregnancy reference 3 to 8 nanograms per milliliter per hour. Random urinary fractionated metnephrines within reference range. Combined renal obstetric ultrasound demonstrates a singleton fetus with normal growth and amniotic fluid volume. Kidneys are normal in size and echo texture, but arterial waveforms were suboptimally visualized. Because of resistant hypertension, right-sided abdominal bruit, hypokalemia, borderline elevated aldosterone with high renin, and episodes of flash pulmonary edema, renovascular hypertension, particularly fibromuscular dysplasia of the right renal artery, is suspected. A diagnostic study safe for both mother and fetus is needed, as prior imaging did not adequately assess renal artery flow. Which of the following is the most appropriate next diagnostic test to confirm renovascular disease in this patient? Option A, computed tomography angiography of the renal arteries with iodinated contrast. Option B, gadolinium-enhanced magnetic resonance angiography of the renal arteries. Option C, duplex Doppler ultrasound of the renal arteries. Option D, captopril-enhanced radionuclide renogram. The correct answer is option C, duplex Doppler ultrasound of the renal arteries. The most appropriate next diagnostic test is duplex Doppler ultrasound of the renal arteries. This pregnant patient has several red flags for renovascular hypertension, especially fibromuscular dysplasia, early onset hypertension, persistent hypertension despite pregnancy-compatible triple therapy, flash pulmonary edema, hypokalemia, and a high-pitched, continuous right periumbilical bruit radiating to the flank. Her aldosterone is only borderline elevated for pregnancy, while renin is high, which is more consistent with a renin-driven process than with classic primary aldosteronism. Prior combined renal obstetric ultrasound was non-diagnostic because arterial waveforms were poorly visualized, so she now needs a study that better assesses renal artery flow without exposing the fetus to avoidable risk. Gadolinium-enhanced magnetic resonance angiography is not the best next test because gadolinium is generally avoided in pregnancy unless the benefit clearly outweighs risk. Computed tomography angiography exposes the fetus to ionizing radiation and uses iodinated contrast, so it is also not first choice when a safer diagnostic option exists. A captopril-enhanced radionuclide renogram is inappropriate in pregnancy because it uses a radiotracer and an angiotensin-converting enzyme inhibitor-based provocation strategy, neither of which is preferred in this setting. In summary, the correct answer is duplex Doppler ultrasound of the renal arteries. Primary teaching point: when renovascular disease is suspected in pregnancy, start with the safest high-yield imaging test. Secondary teaching point: an abdominal bruit plus flash pulmonary edema is a classic clue to clinically significant renovascular hypertension. Don't forget to like, subscribe, and share. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine. See video description for disclosures.